Welcome to This is Public Health, the Regimen Grant for This is Public Health. We are continuously podcasting the success stories of public health in Sri Lanka. Today, we are going to interview an eminent public health specialist who worked tirelessly to improve the public health system in Sri Lanka, especially for the sexually transmitted infections and HIV, who is the pioneer in prevention and keeping the country with low prevalence, Madam Sujatha Samarakoon. Good afternoon, Madam.
Good afternoon.
Madam, so we know you are a pioneer in this evolution of this HIV prevention strategies. I think we know since the introduction of this HIV, you are in the public health sector, I think in mid-80s when it starts. So we have a long record that relatively low prevalence, not only for a shorter period, for a longer period, we are maintaining that. It's not only due to the treatment, also the surveillance system we had and the targeted interventions and our strong public health infrastructure. So over the decades, the national response has shifted now. Earlier it was only the awareness campaigns. Now we are more focusing to preventing mother-to-child transmission and harm reduction and community-led outreach activities. So from your perspective, as a senior venereologist and a public health leader, what strategies, decisions or structural strengths which have been most critical to sustaining Sri Lanka's low HIV prevalence, and what emerging vulnerabilities should policymakers to be most concerned about today, I think?
Yes. So fortunately, Sri Lanka, as you and everybody knows, that we have a very good public health system in this country. And all of us as Sri Lankans are very proud of the fact that our health system, preventive and curative sides, both work hand in hand, and also they are both collaboratively looking at the best for our people. So in that same vein, I must tell you that even before the HIV infections were discovered in Sri Lanka, the first case among a foreigner was discovered in 1986, and thereafter Sri Lankan was found to be positive in 1987. Even before that, Sri Lanka was getting ready to face this epidemic. And I must pay a huge tribute to the director at that time, who was a venereologist and a public health specialist, Dr. Jayakuru, and his team, consisting of also of a very strong microbiologist, Dr. Nihal Pereira. They were visionary leaders. I think the core or the pillar of the success lies there. But the foundation that they laid for other people to build up and sustain it as of today. So these are the lessons learned. We as juniors at that time, we saw them as visionary leaders who had a commitment, a dedication, and they had a very close understanding of the public health requirements globally and locally. So they understood from the WHO, and earlier on it was a global program for AIDS. I think it was called GPA, which eventually became UN AIDS, if I'm not mistaken. So they had these various strategies based on evidence. So our leaders were able to recognize them and implement the programs accordingly. So if I remember, they had short-term strategies, mid-term strategies, and then eventually they drew up some long-term strategies. They were all based on evidence. So to give evidence, we had the surveillance system, which was very, very effective. And as you know, Sri Lanka is well known for a very strong sexually transmitted diseases infrastructure program, which was started in 1952 based on the British model. So that was also very supportive to launch HIV prevention, because both are sexually transmitted infections. So in that sense, I think the strongest was, I also must mention that there was good political will that dependent actually on the director and his team, who negotiated with them, who made them understand, and that side was also very strong.
Advocacy was
Very good, I must say. And also the head office in the Ministry of Health, and even in other sectors like the Ministry of Finance, the President's House, and all those people, they were very cooperative, and they all worked in unison. That was something which we should be very proud of, and the young people should also follow, working with other sectors. This is not only a health problem, there is a huge socio-economic problem which is getting worse today. So those were actually the strong foundations that was laid. And also I must mention that screening donated blood for HIV, screening for syphilis was already on, but screening for HIV of donated blood began in the late 80s, if I remember right, somewhere around 89, 90. So those were very correct decisions taken to not to kind of destroy the privacy or the confidentiality of the donors. That was done in a very scientific manner. And so those were the good factors, the good push factors we had. But I must also say that everything was not very rosy. There were some societal problems like stigma and discrimination, because this was a new infection which is sexually transmitted, and you know how the Asian populations look down upon these areas, the commercial sex, the men who have sex with men, and injecting drug use. All those factors are were not very conducive for prevention programs.
Still, it's all are the prohibited things, and they are
legally. Exactly, those are things that people don't like to kind of openly accept. So those were challenges, I think, which the directorate was able to mitigate to a large extent.
Okay, thank you, Madam. So, can you explain that more, because they are since start of this HIV control and things. Some of the few programs, particularly initiated for this HIV prevention and things.
Yes, I think at the beginning, everywhere in the Asian region, even in the Western world, it started with awareness. So the awareness was given to like school children, out of school children, all those vulnerable areas, and also the most at risk populations, like the men who have sex with men, the sex workers, people who inject drugs and use drugs, and also the prisoners. So, and also we have this another group called the beach boys who are very vulnerable to HIV. So those populations were engaged from the very beginning. So general population awareness together with targeted interventions, and also the opportunities for like testing, where the testing facilities were introduced to almost all the STD clinics. There were not many STD clinics at that time, maybe like 20 or 25.
Only major hospitals.
Major hospitals, but today there are about 41 to about 43 STD clinics, and also introduction of these rapid diagnostic tests. Rather than drawing blood and transporting, now you can do it immediately and get the result in 20 minutes. And also basically I think today what has helped Sri Lanka is this community involvement. The people living with HIV, the key populations, they are all kind of very
supportive,
geared to prevent HIV. So those are some of the, and also I must also remind you that we started giving antiretroviral therapy from 2004. That was together, I think the World Bank gave a grant at that time, and then subsequently from 2011 the Global Fund is providing antiretroviral therapy. Then for a short time Sri Lankan government took over in 2016 a transition to support. Then with this COVID and economic crisis, all that, now again the GFATM is funding. So people were not deprived of those rights, I must say. Those are some strong factors that...
Is that reason for that even the other countries, neighboring countries also similarly affected? But I think in my point of view, I think we are far better than the other neighboring countries, including India and other things. So I think all these you mentioned now are the key for this success compared to our neighboring countries.
Yes, we were very much ahead in all our activities, but unfortunately now, you know, with this globalization and all these communication channels, so we are seeing young people between the ages of say 20 to 24 and sometimes even 15 to 19, they are engaging in all these sexual and injecting drug use practices. So those are the things that Sri Lanka has to be very alert, and we don't fall into, you know, the other categories the other countries have faced.
We need to identify a new mechanism to address this issue. Like earlier we identify something compared to other countries and we succeed at that. All countries have the same risk, but we succeed at that. But similarly, now also we need to identify our own culturally mixed one, I think, mechanism.
And universal health coverage, I think, also has to be promoted so that people have access to services.
The primary care also to be strengthened.
That's right. Primary care people also should be mobilized, at least not only like awareness, but integration of HIV testing, and, you know, treating HIV can be kept at a specialized level, but at least testing and referral, then risk assessments, if those are integrated into the primary health care level.
We have something for this. Pregnant mother screening, we are already having something for HIV testing.
That's right, prevention of mother to child transmission started in 2002 actually. So by I think 2021 or 2, Sri Lanka was declared as a mother, mother to child transmission has been made minimal, but that gives the opportunity of antenatal screening and awareness. Those are good opportunities that Sri Lanka has exploited.
Okay, madam, thank you. So for this strengthening this HIV awareness beyond clinical settings, we are talking about hospital settings or primary care settings. In your experience, so what are systematic barriers we have? See, still we have the education sector, the reproductive education and things are there, but we don't know how much it's implemented. So how can we move forward? For still it's a stigma. Is teaching this reproductive health and HIV/AIDS in the school curricula still is a problem. I think we are feeling that.
Yeah, it's a good thing that you brought up this question of there are so many controversies around comprehensive sexuality education. I, as a public health specialist and a consultant venereologist, I must say that people have not been given, I don't know whether even the policymakers have been given the correct perspective of what comprehensive sexuality education is. Because if you know that UNESCO, I think way back in 2018, they have developed some good guidelines. There are about 8 key areas. So it's not trying to teach children unwanted things, but it's teaching children how to prevent, you know, to reduce the risks, how they should face society. So it's a mixture of strengthening your lifestyles. But I don't know how people have got the kind of wrong impression.
It should be approaching the scientific science. It's a science. It's not an emotional way. Teaching it, I think so.
That's right. I don't know where it has gone wrong, but I think I also have been reading the paper articles about it, and I think even from the health side, nobody has highlighted that this is a accepted strategy, where UNESCO is not just going to throw away some strategy. You see, it's a very well articulated 8 key areas are there. I think it's 8 key areas. So those, if we follow that, I don't think there should be any dispute. But I really don't understand what has gone wrong.
I think that it's not only with the Ministry of Health. I think the Ministry of Education, they also need to realize it. And also the
yes, that's right. I think it's up to the Ministry of Health. I don't know how far they have been brought into this these discussions, but the Ministry of Health should really guide the other stakeholders. Because at the end of the day, it's the people who are suffering, right? Yes. It's all these reproductive and sexual health consequences are suffered by people, right? It's the health that is affected. Teenage pregnancies, sexually transmitted infections, HIV, child abuse, all these are health related. So I think it's time, I don't know whether I'm correct in saying that, but they're re-looking at it.
Yeah, that's the thing. I also, now next question is that how does this intersection between gender, inequality, so these are the things you also mentioning these ones, so the rape or the sexual violence or the child abuses and the power, so how this think the high prevalence for this HIV infection, and what multi-sectoral interventions we needed in the country. It's not only a health ministry one.
Yes, absolutely. I think the law enforcement, the lawmakers, those people also should be made to understand, like say Women and Child Bureau, I think there are these in this district secretariat, there are these officers. Those people can do a lot of work. So I don't know whether they have been trained in that direction, to really make use of those opportunities. So I think a multi-sectoral approach.
And also Sri Lanka, I think almost every ethnicity, we are bound with the religion. Have you ever tried the religious leaders for advocating such preventive programs?
Yes, I must say that, when I was in the national program also, there were lots of, if I recall in 2007, we had this 8th Asia Pacific Conference in Sri Lanka, and one whole day was entirely for religious and faith-based organizations to come to interact and understand. But as time goes on, naturally other problems come up, and people, then there are regime changes in the political field, in the official fields, and somehow or the other these things go underground. But nevertheless they have been tapped, but I'm not saying since of late that trust is rather poor.
So I think that's a good opportunity we have approaching these religious leaders, because these are culturally mingled programming. It's not a straightforward health program like other communicable disease prevention. This sexual transmission infection is something with this culture and things. People are believing that, I think. So how we can...
Yes, that's true. They go hand in hand, and that is why... but from the grassroots levels, I think there are programs that's happening. I think UNFPA started some programs in the north and the east in 2001 or 2, I can remember. But sustaining this and integrating into those ministries is very poor. Right? Now religious and cultural ministries, they should have that in their strategic plan.
That's the thing again. It's not the stigma for the people who are having the HIV or the bad practices. Those who are talking about it also a stigma.
Yes, exactly. You're right. Somebody tries to bring up the subject and take the leadership, that person is also looked down upon.
Yes.
Unless of course in the medical field it's a little different, but in the non-medical field people are shy to come forward. But in that case, I think long time ago, other like Lions and Zonta, those are the people who came forward to bridge that gap. So those things have to now be revisited.
Yeah. Okay. Madam, nowadays more vulnerable people are the youths and young people, more also are more sexually active. So, based on you have very vast experience on research and advocacy work. So, what reforms we needed to strengthen youth-friendly STI and HIV services, particularly in rural areas? I think urban area anyway, semi-urban and rural areas, how we can touch that group of people.
Yeah, I think to approach them is like the way the maternal and child health program, you know, the public health midwife can reach out to any pregnant woman in this country. So similarly, I think we should also there is a strategy for the public health midwife also to reach out to people. For her, it's not that easy. But I think the youth organizations, they are led by the youth. So out of school youth training colleges and even these tuition classes, you know, so many people patronize the tuition classes. So as a result, to look at get them also enlisted in these programs should be important. I think reaching to youth through the health sector is not that easy.
Yeah, India, you have visited several places. Any other country examples we can approach for adapt for this youth? Anything?
Yeah, I think Thailand has some very good programs for youth. That is because they are communities. They have a very strong community organization group, right? This civil societies in Thailand is very strong, and also the religious leaders are also very committed. So we may have to learn some lessons from them and have a very kind of organized program which is evidence based, you know, and with the cooperation of people. And this demand should come from the youth actually.
They should ask.
Yes.
Okay.